Sepsis in infants. So we have a 5-day-old infant, AW, who's brought in by his parents. He is irritable, refusing feeds, and has only had one wet diaper in the past 24 hours. He was discharged from the hospital 3 days ago after an uncomplicated vaginal delivery, and the baby's heart rate is 200, respiratory rate of 70, and a fever of 105 degrees Fahrenheit. He's crying and not easy to soothe. What are your next steps? So what are some information we can actually get from this question? We see that this infant is a neonate based on the age, only 5 days old. And what else do we see? We see some signs and symptoms of irritability, refusing to eat, only had one wet diaper, so we're thinking the patient's dehydrated probably in the past 24 hours and was discharged 3 days ago, okay? And the vaginal delivery was uncomplicated. That's pertinent information. The child does have unstable vitals. The heart rate is 200. For neonates, they usually run on the higher side, but 200 is tachycardic for an infant. Respiratory rate of 70 is also tachypnic for an infant, and a fever of 100, temperature of 105 degrees Fahrenheit is a fever for everyone. Okay. So what do we do? This patient has sepsis. Sepsis isn't that common, but it can be detrimental for patients that do have it. So when we see it, we like to know what's causing it, stabilize and treat the patient, and treat whatever is causing the infection, sepsis. So the most common bacteria that causes sepsis in infants is group B strep and E. coli in neonates. And neonates are less than a month old. So day 0 to 28 is the age of neonates, okay? And then in infants, those who are older than 4 weeks or 28 days, it's usually strep pneumonia and Neisseria meningitidis. Now I put here gram-positive and gram-negative bacteria so that one can easily remember because group B strep is gram-positive and so is strep pneumonia also gram-positive. And E. coli and Neisseria meningitidis is gram-negative. So you remember that the two most common bacteria that causes sepsis in infants, one is a gram-positive and one is a gram-negative, whether you're talking about neonates or infants greater than 4 weeks old. There are also other things we need to consider in a patient that has, and an infant that has sepsis. We have to consider the mother. If the mother underwent intrapartum fever or had group strep colonization, group B strep colonization, if you recall, pregnant women go through group B strep screening at 35 to 37 weeks, right? And if they had premature rupture of membranes, or any form of invasive procedure in the uterus, that can increase the risk of the child developing sepsis. So what does sepsis look like? The signs and symptoms of sepsis are normally non-specific because many things can cause the infant, the neonate, to present this way. So sepsis presents with non-specific fevers, signs of respiratory distress, tachycardia, usually seen in the vital signs with tachypnea or with an increased heart rate. The patient could not be eating, taking feeds either through bottle or breast. The patient could also have abdominal distension, even vomiting, and some neurologic symptoms like seizures and being lethargic and weak. So I have a quick clip of a baby here who could be presenting with sepsis, generally irritable as well. So what do? We want to help these kids that could be presenting with sepsis, which is not good, okay? Like I mentioned before, we want to think about the mother. We want to review the kind of pregnancy the mother had. Was there any complications in the pregnancy? Was the mother group B strep positive or colonized during the pregnancy? Did she receive the appropriate treatment for the group B strep colonization by having intrapartum antibiotics? Those are important to think about. We also want to review the labor. Was the labor premature? Did the mother have premature rupture of membranes? And was there a complication in the delivery? And how was the baby delivered? Was it through the vaginal canal or was it through cesarean section? Because those two could also affect the risks of the child being infected and therefore developing sepsis. After we get that history from the mother, of course, we do want to obtain a history about the patient. When did it start? What symptoms was the patient presenting with? Is the patient feeding well? Is the patient not feeding well? In the case of this patient, we would want to go ahead and give the patient fluids because they're not feeding well and they're not producing enough urine in their diapers. Then we'll go ahead and do a physical exam. We want to be very thorough with the physical exam. We listen to the heart and lungs, listen to the abdomen, palpate, do an abdominal exam, inspect the whole skin. If there's any jaundice, look at the ears, eyes, nose, throat, possible, the skin. Check the fontanelle if it's sunken in the case of this child, because we've heard that the child's not eating well and not producing urine well as well. So we want to do a thorough physical exam on the baby. Then we want to do our labs. It's important to get a blood culture in all infants that we're suspecting are having sepsis. We also get a complete blood count with differentials, get a lumbar puncture, urinalysis, urine culture, and chest x-ray, especially if the infant is having respiratory symptoms or unstable respiratory vital signs. And then we want to go ahead and start empiric antibiotics even before the cultures are back. But we want to, of course, draw the blood cultures or any culture. We want to draw the specimen for that culture before we give antibiotics. So we don't want to waste time between those two steps. The reason why we do that is because once we give the antibiotics, before drawing either the blood or the urine for the culture, we could start to treat the patient and then get a false negative test result, meaning that the sample may not show any bacterial growth. But that doesn't mean we waste time, okay? Treating the patient, I find, is more important than trying to grab labs if that's going to be a hindrance. But ideally, it should be quick, fast, so we can start treating the patient effectively. So for empiric treatment, we want to cover the most likely pathogen that's causing this, right? And then we talked about if it's a neonate, that is the patient is less than the age of 28, it's most likely group B strep or E. coli, right? And then if the child is greater than 28 weeks, then it's most likely strep pneumonia or Neisseria meningitis. And those two have different coverages. So for neonates, we can use ampicillin, gentamicin, or cefotaxime. And then for infants that are greater than the age of 28 weeks, we can use ceftriaxone or vancomycin because those would generally cover strep pneumoniae and Neisseria meningitis. So just a note on the different types of sepsis that can occur in neonates specifically. So if it's happening less than 7 days old infant, like our patient here at AW, we want to give a full workup if the patient is showing symptoms. And here, AW is showing symptoms, right? AW is not eating, AW is lethargic, AW is crying, and the vital signs are quite unstable. So that's a symptomatic neonate over there. We want to do a full workup that we just talked about. If the child is non-symptomatic, so the child looks good, well, but the labs are just abnormal, then we want to evaluate the maternal history to assess risk, okay? Did the mother have group B strep colonization? Was there a premature rupture of membranes? If those things are in place, then our patient is in a higher risk and we want to observe them and carry out the appropriate measures as we observe them to see if they do develop all these signs and symptoms of sepsis. And even after observing them, monitoring the vitals for about a little over a day to 2 days, and if the neonate develops any signs of infection, then we want to go ahead and obtain blood cultures and start empiric antibiotics. If the sepsis is late in onset, that is, the neonate is more than 7 days old, more than a week, then we want to go ahead and do a full workup and obtain a urine culture and other potential infection sources. So let's say if the patient had a chest tube in or a tracheal tube or a catheter, all those points where bacteria can usually colonize and be a foci for infection, we want to take samples from those sources and also test them for any form of bacteria that could be causing the sepsis. In both cases, whether the sepsis is early onset or late onset, we want to treat empirically with antibiotics. And remember, for neonates, which is infants that are less than 4 weeks old, less than 28 days, we want to empirically cover the most likely organisms that do cause this in them, which is group B strep and E. coli. Okay. So in summary, sepsis, although not so common, is very important to evaluate for if it's not differential, because the consequences of not can be crucial to the patient. Group B strep and E. coli are the most common pathogens in neonates, that is, babies that are less than 28 days. And Neisseria meningitis and strep pneumonia are the most common cause in infants that are older than 28 days. It's important to consider the mother because prenatal care, the pregnancy, the labor, the birth, and risk factors can play a role in the evaluation and the risk that the infant faces in having sepsis.